Fifth session of Parvam webinar series. I am Dr. Divya Arun from Team Ayur Wisdom. Today's class is on management of cervical spine and thoracic spine diseases. Our faculty is Dr. Praveen GS. Dr. Praveen completed UG and PG in Draviguna Vijnanam at Trivandrum Ayurveda College. He also worked at Pankaja Kasturi Ayurveda College for 5 years. Now he is working as Senior Medical Officer at GAH Koto Trivandrum. So we are directly starting the session. I am very glad to invite Dr. Praveen sir to the session. Over to you, sir.
Okay, thank you. Am I audible?
Yes, sir. Audible. Audible, sir.
മലയാളത്തിലാണോ ഇംഗ്ലീഷിലാണോ അങ്ങനെ?
ഇംഗ്ലീഷിലാണ്.
ശരി.
ഇംഗ്ലീഷിലാണ്.
First of all, I thank you everyone for inviting me to such a class, especially Team Ayur Wisdom. Actually, the topic given to me is X-ray on, I think, on thoracic spine also. But that's a vast topic, so I limit my presentation to X-ray cervical spine. And wherever possible, I will be trying to explain the pathological aspects as well as some treatment aspects also. So mainly, I think the audience are practicing physicians. So
Please continue, sir. Please continue, sir. No problem.
okay, so I will basically go through how to view an X-ray, what are the basic approaches, and try to explain whatever I do in practice. So we'll have a half an hour question and answer session. So regarding the theoretical aspects or the treatment aspects, you can ask in the question and answer session, I think so. So I'll directly go into the presentations. This is what we usually see. What I hear, I forget. Whatever we hear, usually we tend to forget. We hear all things and all seminars and all other things. But usually what happens is that everyone tends to forget whatever we hear. But if we see something, some pictures or something like that, we tend to remember a little bit. Oh, we have seen that in such as an X-ray there or an MRI there. Like that, or we have seen a Siravedam done or an Agnikarma done. So you'll remember some aspects of that. But if actually one do something, what I do, I understand. That's the thing. So X-ray doing is like that. It is not like you just hear the topic and go home. You will not remember a single bit of the thing. But if you try to read the X-ray in a systematic manner, on a regular basis, then you tend to understand what actually the X-ray is about, how you can say how you can interpret into your theoretical or treatment aspects. Okay, so I will confirm this class only for the cervical spine, and you can ask doubt whenever possible. Okay, so basically, X-ray is actually like we used to take photographs, isn't it? In our younger ages, we develop the film and we see the photographs. Similarly, X-ray is also a type of photography. And the basic mechanism here is that there is a plastic film that is coated with silver bromide and a silver iodide solution. And the film is exposed to an ionizing radiation. That is the X-ray. The chemical changes will take place, resulting in deposition of metallic silver, which is black. So whatever we see in an X-ray, which tends to be black, that means that area has undergone a reaction, and that part has turned into metallic silver, which appears to be black. The amount of blackening, that means you can see different shades in the X-ray, ranging from black to white. So the amount of blackening that is dependent upon the exposure. That means that if a film is exposed to its maximum exposure, that area will be completely turning into metallic silver and it will appear in black. And that which does not absorb or transmit the ionizing radiation, then that area will be appearing white. We'll see how it is. Okay, so depending upon that, these are the basic things which I will be explaining. Most of you know this thing, but for a little more clarity, I think this is the basic technique I use. Okay, the principle is that denser the object means more X-ray it absorbs and whiter it appears. That means if you are having a bone-like structure, that means it's very dense. If you have a fat or a soft tissue-like structure, that is little dense. That means the denser object, more X-ray it absorbs. That means little X-ray, little ionizing radiation will be passing through the film. So that part of the film will not undergo any reaction, or that part of the X-ray will not undergo any reaction to deposit metallic silver, which is black in color. So always what happens is that only parts will be appearing white because the ionizing radiation is not producing any changes in the X-ray film. And less dense the object means less X-ray it absorbs and darker it appears. Less dense means that means it let the X-ray to pass through these tissues and that will fall on the film and that will produce the blackening effect. Right. So when you look into the X-ray, you have basically 5 densities that will be ranging from black to white. In between this black and white, you'll be having different shades of say gray. From black, that means a gray shade which is more close to black, and a gray shade which is more close to white. And that can be different things like from air, fat, soft tissues, calcium, or metal. Right. So basically, what we see in an X-ray will be either air, fat, soft tissue, calcium, or metal. And accordingly, we should be interpreting whatever we see. Right. So in a film, you see that see an area which is black color, completely black. That means that area is occupied by air, right? Like you see in lung X-rays, isn't it? Most of the areas are black in color. So that means that area is mostly contains air. Less dark than air. That means it's a gray shade which is more or less similar to that of black. So that area should be considered as deposited with fat. We'll see the X-ray and we'll try to interpret how it is. Less white than bone. That means it's not as white as bone, but it is whitish. Okay, then it may be either soft tissue or a fluid. And white color, as you see in the bones, that is because of the calcium, right? And more than it's a whitish color. That it's not bigger white color. Then we can consider it as a metal or a foreign body, right? Also, there is you can see in an X-ray shades of 5 different shades from black to whitish, and you can interpret it like that. Right? You see an X-ray here. This is an X-ray of cervical spine. View is lateral, right? So we'll try to see the 5 densities here in this fillet. You can see this area, isn't it? Okay. So somebody could respond. It will be much easy for me to. Okay.
Yes, sir. We are listening, sir.
Okay. So this area, you can see it is dark in color, isn't it? This area. So what will be this area according to our what we studied, what we looked into? What will be this area filled with? Obviously air, isn't it? Because it's black in color. You can see an area here, isn't it? Which is more common, or more or less similar to the black color here. This area. Can you see? Okay, so this area will be fat. And you can see another area here that is most closer to this one, isn't it? The white one, the portion which is deposited with calcium. So this area will be soft tissue, and this area is the whitish one, that is the calcium deposited or the bone. And you can see the whitish one, the metal here, the marker, isn't it? This area is actually, again, this area is filled with air. Can anybody tell which this area is? Okay, I have been a teacher for long, so I will be asking little questions. If anybody could respond, that will be easier for me to go through my class. Don't feel shy. Okay. So this part will be. So this part will be. What will be this part? If anybody could tell. I think nobody is responding. Right, I will go on. So this is again air. That's the trachea part, isn't it? The windpipe. So in this X-ray, it's a beautiful X-ray where you can see the 5 different shades here. Right. This is the black area, which is air. This is the fat one, which is closer to the black shadow. This is the soft tissue. This is the calcium deposited, and you can see the foreign body or the marker here. Foreign body is actually outside the body here. Sometimes it happens that the foreign body will be inside. Right. So that's how basically the different shades of X-ray should be interpreted. Okay. Sometimes what happens is that some X-rays will be underexposed and some X-rays will be overexposed. That's depending upon how the technician exposes the X-ray into the patient's body. So for a fat person like me, I am little fat. So for a fat person like me, the amount of X-ray that should be exposed should be a little more than a X-ray that should be exposed to a thin person. So what happens is that sometimes the technician will make mistakes. Like he will be overexposing the film with more amount of X-ray falling on the film, so that the X-ray will be appearing more or less darker than what it should normally be. Like what happens is that if the X-ray is exposed to a higher intensity, more X-ray will be penetrating through these structures, like the soft tissues, the fat, etc. So what happens is that since more X-ray passes through these structures, the X-ray film will be reacting more, and more metallic silver will be deposited on these films, making this appear black. So what happens is that sometimes what happens is that the X-ray technician will be exposing the film to a much lower intensity than required. So these structures will appear or are more whitish than what it should normally look. So what happens is that if there is a foreign structure or something like that here, or a nodule or a calcified mass inside this thing, if it is an overexposed film, we may miss that. Or if it is a lower exposed film, it may appear that there is some opacities in these areas, which is actually not there. So as a clinician or a physician, you should be actually looking into how the quality of exposure on this film should be. So in this film, you can see that all the 5 shadows can be well appreciated. So this is a fairly good exposed film. You can see this one. It's an underexposed film. Can anybody tell what is how a chest X-ray should be looked into to understand whether it is properly exposed or not? Can anybody? So if you are looking through the cardiac shadow, this is the cardiac shadow, isn't it? Okay. If you are looking through the cardiac shadow, you should be able to see the intervertebral disc spaces here. Right. Actually, in this film, we are not able to appreciate the intervertebral disc spaces while looking through the hard shadow. And you can see all these white patches here, which is actually not there. This happens because of an underexposed film. So a clinician should be actually aware whether the film is an underexposed film or an overexposed film like this. See here, it's an overexposed film. You can see all the dark shadows here. And actually the ribs are not at all visible here. Isn't it? You cannot appreciate the ribs on the medial region. Right? Because it's an overexposed film. Right. So these are all factors which should be considered before actually reading an X-ray. Right. Whether it is an underexposed film or an overexposed film. Right. Moving on. We actually come to the spine aspect. So, actually we are dealing only with the cervical spine in this class. Actually, the topic given to you contains the thoracic aspect also, but still, we are considering the cervical aspects only. Cervical scan can be anatomically as well as clinically. You should be differentiating how many cervical vertebrae are there. There are actually 7 cervical vertebrae, isn't it? And there are 8 cervical pairs of nerves. 7 cervical vertebrae and 8 pairs of nerves. And before going into the clinical aspects of reading an X-ray, cervical spine X-ray, you should understand that you should be anatomically as well as clinically dividing the cervical spine into 2 things. One is the craniocervical part, and another one is the lower cervical spine. Right. The craniocervical spine consists of the upper first 2 vertebrae, that is C1 and C2. You'll see how it is clinically important. And C3 to C7 consists of the lower cervical spine. Right. It's also quite not only anatomically different, but also clinically significant also. How C1 and C2 are called as atlas and the axis, isn't it? They are actually anatomically very different from a typical cervical spine. Also, the C7 is also a bit different, but basically all the aspects of the typical cervical vertebrae are retained by the C7. But C1 and C2 are anatomically very different. You should have studied in the anatomy classes. Okay, so C1 and C2 should be differentiated, and C3 to C7 should be a different aspect. So C1 is called as, just I'm going through basic anatomy. If anybody, if all of you know this thing, please bear. Anybody, just to refresh your knowledge, C1 it's called as atlas. Actually, this thing does not have a vertebral body. Only vertebrae which does not have a vertebral body is the C1, first one, called as atlas. It's actually like a ring. It consists of an posterior and anterior arches. And it actually applicates with the skull through the occipital condyles. Okay, to form the atlanto-occipital joint. So this is how it looked like. So it does not have a body, right? There's an anterior arch and a posterior arch, right? And we have a vertebral foramens here. That we'll see how clinically important that is. And the second one is called as axis. Actually, it has got a body and a peg-like process. The projection called as the dens or the odontoid process. Now, many of you have heard of this thing. And these 2 things, atlas and the axis joint, to form the atlanto-axial joint. And actually, there is an atlanto-axial ligament which holds the dens with the axis with the atlas, like this. This is the dens, and this is the ring-like structure. Can you see? You can see the ring-like structure. This will be hold. The dens will be kept in this position by a ligament, which connects this thing called as atlanto-axial ligament. So this ligament is very important. Clinically, also it is very important because in a congenital disease called as Down syndrome, we have seen patients with Down syndrome. This ligament will tend to be very lax. and causing instability in the Atlantic axial joint. And also in most of the advanced chronic rheumatoid arthritis cases also, you can see that the Atlantic axial joint can sometimes be, sometimes that ligament can get, that ligament can break and produce instability in the Atlantic axial joint. It's quite a red flag like situation. Right. So we'll go through such x-rays and try to explain what we can manage like that. So second one is the axis. Axis, actually this is the dents. Okay, and the ring-like structure will be coming over like this, and there will be a ligament like this, which will be holding the dents into the atlas. Right, and there is a special feature for that. It's not clinically significant, but it is called as the spinous process will be bifield, like this. Okay, it's not clinically so significant, but one of the processes. There is you can see the foramen here. Okay, the transverse foramen. This is how a typical vertebrae look like. Typical cervical vertebrae. You can also see the transverse foramen. Through this structure, will be passing the vertebral artery. Right. Through this structure, vertebral foramen will be passing the spinal cord. Right. And you have a small structure. So you will see that this structure is called as the pedicel. Pedicel. You can see the body, articular facets, and all this. Just going through the anatomy, don't feel bored. We'll see how these structures are seen in an X-ray. Then you will find that one very interesting. Right. And from C3 to C7, the C7 is the most prominent vertebrae, and hence it is called as the vertebrae prominence. And you can palpate on the back. This is the most prominent spine you can palpate on the back. Okay, this is regarding a basic anatomy regarding cervical spine. Right. We'll now move on to see how an X-ray or what X-ray views we should be taking, or how an X-ray should be interpreted. So, there are many X-ray views that are taken in clinical practice, but as an Ayurvedic physician and the type of diseases which come across, I feel that only these 4 views is important to us, and we should be focusing on these X-ray, these views, and trying to find out the pathologies. Right. Even though there are many other views, only these 4 views are of much importance. Otherwise, other views you can take. There are swimmer's view, flexion view, extension view, different types of views. That is mostly related to surgeons. That was once taken when CT and MRI were not so much evolved. Nowadays, such views are not taken, but still, X-ray being the cheapest and most convenient way, this only we need only these 4 views. That is, what is the AP view or the anteroposterior view? You need a lateral view, you need a peg view that will see what it is, and you need oblique views. And lateral views can be of 2 types, right lateral and left lateral. You will see how it should be described. And peg view is a modified AP view that we will also see. And oblique view, which I think is the most important view that a physician should be taking, especially Ayurvedic physicians. Oblique view should be given prime importance. Right. So moving on, looking to the anteroposterior view. This is how an X-ray is taken by a technician. Just to know, the film is put on the back side. The patient will be lying, and X-ray will be passed like this, and you will get the film. Right. So this is how an X-ray AP, classical AP should be looking. First of all, there are many factors like name, date, etc. But this film does not have that. But one of the main things you should be looking is the marker here. Whether this is the right side or which one is the left side. Usually all the technicians keep the marker in the appropriate position so that you can identify which one is the left side, which one is the right side. Right. And you can see a series of vertebrae arranged like this from the top to bottom. Right. We will try to see what all structures you can see, anatomical anatomically, and then you'll see what the pathology is. So, first of all, you can see the vertebral bodies here. This is one of the body. This is another body, vertebral body here. This is another vertebral body. This is another vertebral body, and so on. Right. And you can see small projections here also. Before that, I will tell you that this is you can appreciate the 5 shadows here also. See, this one is the black one, black shadow. Right. So this part is air. You can see a beautiful X-ray where this part consists of fat, closer to black shadow. So this part will be fat. So this gray shadow is closer to the white one. So this soft tissue shadow. This is the bone shadow, and this is the metal shadow. Right. So you can identify what is called as the body, and there is a small ear-like projection here, called as the uncinate process. This form a joint here that we will discuss later. So, vertebral body, spinous process, right? Spinous process, right? Spinous process can be seen. This is the lateral mass, including the vertebral, the transverse foramen, which we saw in the early diagram. So this all together form a column-pillar-like structure. Yeah, this part, this portion is formed by the lateral masses. Right, this portion. You can see the small transverse processes coming because the upper cervical vertebrae does not have a transverse process. Transverse processes are actually developed while in the C7 vertebrae and actually in the thoracic vertebrae and lower down the lumbar vertebrae. Right. So you cannot actually see a well differentiated transverse process in the cervical region, but still you can see small projections. Yeah. Okay. So this structure is the spinous process. Like that. And you can see a black shadow here. Can you see that? Okay. You can see that black shadow here. So this black shadow is actually air, the trachea, having the windpipe that is going through here. And you can see a structure here. Okay, this structure is very important. This is the transverse process. First thing is that you should be able to count the vertebrae. Which vertebrae is C7, which is vertebrae C6, C5, which is C4, so on and so forth. So the prime before counting that, one should be able to understand what one should be able to see which one is. Always there is a confusion like whether this is the C7 or is this the C7 or is this the C5 or like that. So a simple technique, a trade of a trick which should be used is that you can see the transverse process here, isn't it? This is the transverse process. Okay. All these transverse processes of these cervical vertebrae will be pointing more or less downwards. You can see this transverse process. Either parallel or it is pointing downwards. You can see this transverse process is either parallel or pointing downwards. But this transverse process is pointing upwards. Can you appreciate that? Let's see this. Okay. Whenever a transverse process is pointing upwards, that means that transverse process is originating from the thoracic vertebrae. Right. So you can see the transverse process here. You can see the transverse process here originating from this vertebrae. From this vertebrae. So this is the T1. So naturally this is 7. 6, 5, 4, 3. 2 cannot be seen because of the presence of shadow produced by the mantle. Okay. So that is how you count the vertebrae. That is also important to find out a pathological condition. So this is C7. This is 6, 5, 4, 3. 2 cannot be visualized. Right. So you can see another thing here. Can you see the structure here? This structure. This structure. What is this? This is actually the pedicel. Right. Pedicel is a structure like this. small projection which connects the vertebral body with the lamina. So when you're viewing it from the anterior side, it will appear as a circle like this. Right. So that is how you can see it's like an eye. It's an eye, isn't it? Okay, it's like an eye which is looking at you. Right. So this structure is also very important because absence of this pedicel is a primary indicator of bone CA, secondary bone CA. So please look whether all these pedicels are present or not. It's called as winging outside. We'll see that later in the pathology. Right. So these are the pedicels. ഡോക്ടറെ ഇങ്ങനെ പോയാൽ മതിയോ അതോ കുറച്ചുകൂടെ സ്പീഡിൽ പോകണോ അങ്ങനെയാണ്?
ഇല്ല ഡോക്ടർ, ഓക്കെയാണ് ഇങ്ങനെ പോയാൽ മതി. ഓക്കെയാണ് ഡോക്ടറെ.
അത് നമ്മുടെ സാധാരണ ക്ലാസ് എടുക്കുമ്പോ ആൾക്കാർ റെസ്പോണ്ട് ചെയ്യാം, കുറച്ചുകൂടെ എളുപ്പമാണ്.
എനിക്ക് തോന്നുന്നു ചാറ്റ് ബോക്സിലൊക്കെ ഡോക്ടർ ചോദിക്കുന്നതിന് റിപ്ലൈ കുറച്ചുപേര് ടൈപ്പ് ചെയ്തൊക്കെ ഇടുന്നുണ്ട്, ചാറ്റ് ബോക്സിൽ ഇടുന്നുണ്ട്. ട്രക്കിയാന്നൊക്കെ ഇട്ടുണ്ടായി നേരത്തെ ചിലര്. ഓക്കെ ഡോക്ടർ, ശരി.
എന്തെങ്കിലും സ്പീഡ് കൂട്ടണോ കുറയ്ക്കണം എന്നുള്ളതൊക്കെ പറഞ്ഞോണേ.
ആയിക്കോട്ടെ
പോകുന്നത്
ആയിക്കോട്ടെ ഡോക്ടർ,
പറയാനുള്ളത് ഓക്കെയാണെന്ന് തോന്നുന്നല്ലേ കേസ്?
ഓക്കെയാണ് ഡോക്ടറെ, കണ്ടിന്യൂ ചെയ്യാം, കുഴപ്പമില്ല.
ശരി. So this is the okay, you can see that. Okay, so what will be this structure? Chat box can reply in the chat box if anybody is. Okay, so first this is the first rule, right? Most people tend to say confused with the clavicle, isn't it? So what is one of the main tricks that can be used is that you can view you can take the transverse process as one of the indicator, and you can see the articular part here also. This is the first trick. This will be the second trick, third trick, and so on. Right. Here you can see both the clavicles. Okay. So apart from what you look into the anatomical structures, one other part which you should be looking is that whether the X-ray is rotated or not. That means when you take an X-ray and we are positioning like this, sometimes it happens that the head may rotate on one side, or it may be caused due to muscular spasm. You can see this muscles here, isn't it? This groups of muscles. The spasm can go here, or the spasm can go here. If the tension on this side and this side are equal, then the spines will be more or less in the center, going like this. Suppose there is a spasm in this part, that means this spine can go this way. Or if there is a spasm here, this spine can go this way. There is a little bit of rotation in the spine. So what a doctor should be looking is that there should be a clinical examination whether there is a spasm or not, or is it an error made by the technician itself. Most of the time, what in my clinical experiences I see is that most of the technicians nowadays make so many mistakes by positioning the X-rays. So one should be very careful before assessing an X-ray that whether all these aspects are looked into. This can come through constant clinical practice, constant looking into X-rays. You cannot get it in 1 day or 2 day or 3 day. Take years of practice, but this you should be looking very carefully whether this spine is coming exactly in the center between the two clavicles. Exactly means more or less exactly. It cannot be pinpoint precision should not be expected in humans, but still more or less the spine should be coming in the center. If you take a distance from this clavicle to the spine and this clavicle to this spine, it should be more or less center. And from this spine, all this spine should be in alignment, more or less in alignment, not perfectly aligned, but more or less aligned. That means there is no rotation. So this X-ray is wonderfully taken with all the shadows, you can see all the 5 shadows. The hair shadow can be seen, the fat, the soft tissue, bone. You can see on all the anatomical structures, the unstable process, the vertebral bodies, of course, the intervertebral disc spaces. Intervertebral disc spaces can be seen. Spine can be seen. The pedicels can be appreciated well here. Vertebra can be seen on both sides. The transverse process pointing upwards can be seen. Clavicle can be well appreciated. And of course, the apices of the lungs can be well appreciated. Isn't it? It's the lung apice. Right. And this part should be especially looked into. Very important. Please, every doctors, please keep this in mind. Whenever you take a cervical X-ray, after looking into these areas, please visualize this area. Okay, this is an area where you can see an important pathology called as Pancoast tumor, PANCOST, Pancoast tumor. It's a cancerous condition. You should not be negligent that you missed that in an X-ray. Right. So please look into this area. The apices of the lungs, very important, Pancoast tumor, this area. Okay, we'll see a pathological condition where that Pancoast tumor is. Okay, that is how you generally go through a AP view. It's a normal X-ray where you can see all the anatomical structures. Right. Okay, here also, this is not a very good, this is an overexposed film. Just to show you. Okay, we can see the other X-ray where we can appreciate all the different shadows, isn't it? The 5 shadows can be very well defined. It's very well defined. But you can see here, you can see the hair shadow, but not the fat shadow or the soft tissue shadows as clearly as the X-ray previously we saw, isn't it? This one is very clear. But look into this one, isn't it? This is an overexposed shadow, overexposed film. But we can see the body structures fairly well. So, as a doctor, you should be viewing this as an overexposed film, but well-defined body features. Here also you can see the bodies, vertebral bodies. How to count? You can see this transverse process pointing down. So this is the C6 vertebra. Right. This one is pointing upwards. Here you can see the transverse process pointing upwards. So this is the T1. This is the first rib. This is the clavicle, second rib. Right. The spine can be seen more or less the center of the clavicles. So we're well aligned. Right. So 7, 6, 5, 4, and 3. Right. The pedicels can be well appreciated. Right. Should be considered as a normal X-ray, but overexposure. Here, what happens is that such overexposures can make a Pancoast tumor here missed. Right. There will be opacity here. Right. In a Pancoast tumor, there will be opacity here. There is a small opacity. What happens is that if this is an overexposed film, and if there is a Pancoast tumor like thing here, the X-ray will penetrate this opacity and will appear that portion will appear normal. Right. So that mistake will be that can be made, but clinical science should be looked into. Right. So that is how you look in there. Right. Going on. So another review again, not well taken, overexposed film. I am showing this because you should be able to understand what is an overexposed film. This types of film commonly comes. Right. In your clinical practice, nowadays digital X-ray is there, but still, this type of X-rays can be seen. Overexposed films are common. So, again, here also you can see all the others. You can see the pedicels here, the spine, vertebral bodies, isn't it? So this one is the C6 vertebra because the transverse process is pointing downwards, right? And the spine is going like that. Okay. Anybody need a clarity in this aspect? Can very well ask a question. And we move forwards. Now comes the second one, that's called as the lateral view. So lateral view can be, there are two views actually, right lateral view and the left lateral view. So left lateral view is taken with the film kept on the left side, the X-ray beam coming from the opposite direction, vice versa, right? As a clinician, when you write a X-ray, when you give your prescription, X-ray cervical spine or C spine AP lateral, you should specifically specify which is which side you should be, which side the X-ray should be taken, because the patient comes with right side radiculopathy and the technician takes a left side X-ray, you will be missing important clinical findings in the X-ray, right? So if a person comes with left side radiculopathy, then or a left side neck pain, then the prescription should be X-ray AP lateral left, right? Should not be just writing AP lateral. That's not the right way to prescribe. Should be actually pinpointing which side it is, left side or right side. That is the preliminary thing. Most of our doctors make a mistake like C spine AP lateral. It's not bad, but still, when you give a prescription, it should be actually pinpointing which side that should be taken. I'll take lateral as well as oblique, that you will see. Right. So this is how it is taken with the patient lying. And you will get an X-ray like this. Okay. So this one and then the other one. Okay. So it is a properly exposed film. Why? Because you can see the air shadow, that shadow, soft tissue shadow, and the bone shadow with the metal. Right. So here, another one. Here you can see it's an overexposed film. Again, well, compare this one, this one with this. You can see this is a properly exposed film. This is a overexposed film. Right. That assessment should be done before you make a reading. Right. So what are the structures you can see in a lateral film? You can see. What is this? What is the structures?
And
Spinous process. Okay. This is a spinous process, and this is the most prominent one, isn't it? So this makes it the C7 vertebrae. So this is 6, 5, 4, 3, 2, 1. Right. Okay. So let us try to identify what are the anatomical structures here. Which one will be this one? Okay, we'll see. What is it? What is this structure? What is this structure? This structure. That's called as a lamina. Okay, lamina of the vertebrae. Right. And you can see a joint here. Can you see this? Can you see this? It's very important. Very important joint. Most of times, what happens is that we are always predisposed with what is called a disc problem, IEDP, disc degeneration, all that stuff. But we usually tend to miss this one, the facet joint. In my clinical practice, I have seen that around 60 to 70% of the pathologies are coming from this part, facet joint. Okay, this is called as the facet joint. Facet joint is produced by two structures. One is called as the inferior articular process, and the other one is called as the anterior articular process. Superior and inferior articular. So the vertebrae has an inferior articular process like this, and there's a superior articular process like this. Okay. So these two things, the inferior articular process and the superior articular process, this tend to form a joint here, like this. This is called as a facet joint, and this is a synovial joint, like the knee joint or any other synovial joint. This is also synovial joint, and this joint is vulnerable to all the diseases that you see in a knee joint. Right. Any disease that occur in a synovial joint will be coming in this area, like osteoarthritis, rheumatoid arthritis, OT arthritis, any type of TB, anything you associate with a synovial joint, you can see it in these joints, right? These joints. Right. So this is an important structure to be looked into. This is called as the facet joint or the apophyseal joint. Very important. Right. Then you have the vertebral bodies, and you can count it down. Then you have the intervertebral disc cases. You'll see the pathologist later. You're looking at a normal X-ray. Okay. So these are the intervertebral disc cases. You can see here. Then you can see a space here. Okay, space here. There's a retropharyngeal space and the retrotracheal space. This is very important. You will see in the next X-rays what that means. And you can see the mandible here. Okay, this is the hyoid bone here. This is the trachea. This is the thyroid cartilage. You can see here. A little bit of ossification has taken place. Let's say it more or less look like a soft tissue. And you can see a structure here. What is this structure? If anybody can tell that, what is this structure here? Very important thing. Anybody who could respond? What this structure is? No? I told you earlier that there is one called as the dens, and that dens is surrounded by the ring of the atlas. Okay, so the dens comes in this part, and this is the ring of the atlas, the anterior arch of the atlas coming here, and there is a small joint here also. That's not clear in this X-ray. We'll try to see if that is clear in some other one. Okay, so that there is a small joint here also that is called as the axial joint. That is very important to assess whether this joint is stable or not. Okay, that joint can get unstable in rheumatoid arthritis, chronic rheumatoid arthritis, unless and other we assess that joint. Sometimes it happens that in our practice we have got therapists who will do all the massage like this. They will do some manipulations this area, and this if that is an unstable joint, that could produce a lot of problems, right? So that is the axial joint here. Going on, you see, usually the cervical vertebrae has got a lordotic curvature in its anterior side. Okay, curvature on its like this. It should be like this. Okay, you can see a straightening of the lordotic curvature here. That can be assessed by 3-4 lines. Not that important for us, but still, there is Spondylolisthesis, that is slipping of vertebrae over the another, that can be assessed by looking into this one. This is the anterior vertebral line. This is the posterior vertebral line. This is the interspinous line, and this is the posterior spinous line. Not that important, right? So to see whether there is any stepping. If this vertebrae flips over like that, there will be a small stepping like this. Okay, so that aspect should look like that. So this is what I told you, that there is two spaces here called as retropharyngeal space and